Hello, my name is Sherry Grigsby, and this is my final practicum presentation for HCA 670. My practicum took place at the Southern Nevada Community Health Center, and my project was focused on improving the accuracy of HIV linkage to care data to support Federal Uniform Data System reporting, known as UDS, which is a mandatory annual data collection process required by the Health Resources and Services Administration, also known as HRSA, for federally qualified health centers. My intent is to walk you through my site experience, how the needs for this project surfaced, what the work actually looked like, where things ended, and what I am taking with me from this experience. The SNHC site is a federally qualified health center operated by the Southern Nevada Health District. When it opened in 2018, it served about 6,000 patients. Last year, the clinic served over 15,000 with almost 49,000 clinical encounters. Most of their specialties are in-house, so patients are able to get comprehensive care in a single visit. Now, here's the part that shaped my entire project. 58% of these patients are uninsured and only 28% carry Medicaid. A clinic like this survives only on grant funding, well, mainly on grant funding, HRSA compliance, and accurate federal reporting. Data accuracy is not paperwork here, it's survival. The need surfaced during my first 3 weeks of conversations with my preceptor and the quality coordinator. Two grants drive the quality work at this clinic, and each one carries over 65 different sets of criteria that have to be demonstrated through documented processes and measurable outcomes. The QI team had built processes, but no one was able to confirm whether those processes were actually working as intended. I ran the manual validation, and the problem was very real, very apparent, very quick. Azara was reporting 24 of 26 patients meeting the HIV linkage to care measure, and only 11 of those patients actually qualified. That gap became my project, improving HIV linkage to care data accuracy to support UDS compliance. My goals flourished out of the problem itself. Validate the data by hand so we know which patients truly met the measure, meaning newly diagnosed and linked to care within 30 days. Trace the inflated numbers back to their source, wherever that lived between eClinicalWorks documentation and Azara's report logic. Fix whatever we found at the system level, not with the manual workaround, so the correction would sustain itself after I left. And along the way, support the clinic's first patient care model medical home, known as PCMH accreditation, by collecting evidence for 3 of its criteria. Let me be honest about the barriers because they shaped everything. I was on site 1 day a week. When my visit ended, my ability to push the work forward ended with it. So I learned to show up with focused questions and a running agenda and to trust the right people in between. Communication was its own challenge. The quality coordinator wasn't consistently included in the clinical meetings that affected her own reporting, so answers to my questions moved slowly through those channels. And progress inside a government organization moves at its own pace, which is slow. The Azara fix sat in a vendor queue for weeks while everyone involved agreed it needed to happen. One barrier is still out there, and that is if the reprocessed numbers come back wrong or more, which means more troubleshooting rounds to follow. The work itself unfolded in phases, and each one opened the door to the next. It started with manual validation. I pulled charts in ECW and built a data validation log, which is what confirmed only 7 of those 26 patients actually met the criteria. That evidence is what helped me get the right people into a meeting, which was the Ryan White leads, a RN, the program educator, and together we cut more than 25 inconsistent site labels in Azara down to 3 standard names. Digging deeper revealed the real root causes. The numerator logic only recognized brand name medication, so every patient that was on generic medications was invisible to the report, and the diagnosis facility field was pulling external sites into the denominator. Once we knew that, the fixes went in at the system level. The facility field was relabeled. Both generic and brand medications were mapped into the logic, and the educator went back and corrected every flagged historical record. Because it was all fixed in the system itself, no training was ever needed. This slide is the whole project in 2 numbers. 24 out of 26 reported before, 11 confirmed after validation. That's the distance between a number on a dashboard and a number you can defend in a federal audit. The corrected mapping instructions are with Azara now, and once the updates take effect, the reprocessed results will be checked against my validation log. The project also fed the accreditation work directly. I identified more than 25 qualifying HIE examples for the CC15 criteria and compiled telephone encounter evidence for ACO4, both going towards the clinic's first PCMH accreditation, which is a huge win for the clinic and the population it serves. The project was received as a missing piece, not an external review, and I could see the difference in the data. The quality coordinator gained a validation partner. The clinical team gained clarity on how their documentation drives reporting. Leadership gained numbers they could finally trust. In my final evaluation, my preceptor kindly wrote that my contributions were vital to the accreditation process and that the workflows I established will continue beyond my time here. But the moment that told me the clinical team truly bought in was watching the Ryan White educator personally correct every flagged historical record once we found the root cause. Nobody assigned him that, but instead he owned it. Sustainability here starts with knowing exactly who owns the work. Felicia maintains the measure as quality coordinator, and David provides administrative oversight. My handoff recommendation to Felicia is a short reference guide covering the corrected drop-down selections and the reasoning behind them, folded into onboarding so the knowledge doesn't walk out the door with turnover. The deeper protection is that these corrections live in the system itself, in the ECW field structure, and the Azara report logic. Once reporting is confirmed accurate, the manual tracking workaround will be retired. And I want to say that plainly. Retiring it is not the process failing, but it is a sign that the system is finally working as intended. The next steps are concrete and they're already in motion. First, Azara implements the updated mapping instructions that are in their hands right now. Second, the reprocessed numbers will be verified against my validation log, and anything that is still off will drive the next round of corrections. Third, the handoff, which I passed on to Felicia as the measure's owner going forward, with David in administrative oversight, and our weekly meeting structure will stay in place to support her in the future. And finally, the last The last six CC15 HIE examples split between the Decatur and Fremont locations will be selected for the audit submission. I came into this practicum with 10 years of health plan compliance and operations experience, and my goals were to lead inside a clinical environment, sharpen my independent judgment, and study how effective administrators actually operate. The growth showed up in ways that I didn't expect. When the quality coordinator was out early on, I taught myself both systems instead of waiting for direction, and I learned that assessing a situation and moving without instructions is a completely different skill than executing a task. I also refined my ability to communicate across areas, technical detail for informatics, workflow clarity for clinical leads, high level updates for leadership in a new setting. But the biggest lesson came from proximity. My desk sat inside my preceptor's office, and every day I watched a steward leader connect administrative decisions to patient experience and treat staff, patients, and partners as whole people. That's the administrator I intend to be. So, what am I actually taking from this? Harm can come from a spreadsheet just as easily as an exam room. Inflated denominators drive real decisions about actual patients, which makes data accuracy non maleficence in administrative form. Systems theory stopped being abstract for me the day one mislabeled drop-down field rippled through the reporting logic, federal metrics, and funding criteria. I was able to use skills that I picked up along the way, like validate before trusting information, because a dashboard number is a claim, not a fact, and the gap between 24 and 11 is the distance between the two. I also learned that progress has its own pace, especially in government organizations. Knowing when to push and when to wait turned out to be a leadership skill, not a compromise. These are the scholarly sources that informed this project across my practicum journeys and coursework this term. Thank you for watching.